Good morning, everyone, and welcome. My name is Diana, and on behalf of our team from the Clinical Emergency Hospital of Bucharest, we want to thank you all for helping us make this event possible. We are now very happy that this Congress has reached its 7th edition and that we have together a lot of colleagues that are very passionate in advanced endoscopy and also in challenging cases from all over the world. We wish you all a pleasant stay in Bucharest and thank you for being with us. And now, let's start with the live cases. We will start our first case with a 50-year-old female with a personal medical history of thyroidectomy a few years ago that presented in our clinic in February 2026 for epigastric pain. We proceeded an upper GI endoscopy and also an endoscopic ultrasound, and we found a 5 mm gastric subepithelial lesion. The procedure that will be done today for her is a gastric STER, a submucosal tunneling endoscopy resection by Dr. Georgios Mavrogenis, Professor Dr. Constaninescu, and also Dr. Vlad Rizescu.
Good morning, everybody. I would like to explain you why we're doing STER in this case. So when we have a submucosal tumor of the stomach, when this tumor it is attached to the muscle layer, we have probably we are obliged to perform perforation intensively. If we do STER, we will follow the following steps. So here you see our animation, and the plan is to make an incision at the mucosa in order to access the submucosal space. Then we will prolong the submucosal tunnel towards the lesion, and then the difficult part will be to go above the lesion, and the most difficult part to go below the lesion, so the access will be challenging. Then, if the lesion is strongly attached, originates from the muscle layer and penetrates the muscle layer, we'll have to do perforation. At this step, in case of capnoperitoneum, we have a syringe filled with normal saline and we are ready to puncture the abdomen in order to decompress it and don't influence and make difficult the ventilation of the patient. The other possible solutions for such cases include EFTRD device, but it is not very efficient for full thickness resection of lesions that come origin from the muscle layer. It is better suited for colon and duodenum. Then we can do intensively full thickness resection with perforation and closure as the Chinese do, enclosed with endoloop and clips. We have also STER, and if the lesion does not penetrate the muscle layer, we can go with classic ESD up to the level of the muscle layer with intermuscular dissection or even up to the serosa without perforation. But in this case, probably we'll do STER, and we will see the steps right now. Thank you.
We are hearing the RC, yes.
All right, perfect. So this is the lesion. So when we appreciate such a lesion, we have to understand in our mind whether the lesion has an extra luminal component. So when we see this lesion, it looks like 50% of the pores of the lesion is inside the lumen and 50% outside. The next step is to touch the lesion and see if we have any mobility. So we touch it and we see if it slides above the muscle layer. So mobility is, let's say, not so good. We will discover during dissection whether there is a strong muscle attachment. Now, we have two options. One, to do a longitudinal incision, which is easier to close, or to do an horizontal incision, which is more difficult to close, but give us faster access to the lesion. Another choice we have to do is to decide whether we will start the tunnel 3-4 centimeters more proximally. This is best for the esophagus, or we're close to the lesion, because in the stomach we can get easily lost and searching the lesion for hours. So I will start my incision here. So please give me injection needle.
Spasmotech? What do you mean?
Our endoscope is a very slim endoscope, 7.9 millimeters in diameter. Is called 840 TP. Is the newest endoscope by Fuji, and it has the advantage of a large therapeutic channel and a water jet. So this is the ideal slim endoscope for tunneling. In terms of the rest of the equipment, we have the Herbe Bio 3 My current setting is endocut I effect 2 3-3.
Georgios, can you hear us?
Yes, I can.
Morning, this is Pavel.
Good
Very
morning.
nice case. Quick question.
Yes.
What is the
Dissection.
value of endoscopic ultrasound in
Yes.
determining the
Very good. Stop.
layer of the lesion? How
Ve-
reliable is it in the
Stop.
stomach
Stop.
for this size of lesion?
Very good question. So ultrasound has to give us two answers. First of all, to tell us whether it's leiomyoma or not, in order to know whether we have to be very aggressive or not. Second is to determine the connection of the lesion with the muscle layer or the serosa and identify the component of the lesion that goes outside of the serosa. In this case, probably we will provoke an intentional perforation. So we should be ready for that. And also have a surgeon as a backup. We have a surgeon as a backup?
No. No.
You're very confident. Okay, let's start. I have to verify that I'm at the right place. All right. I have placed some marking before, just in case. Okay, so I think here we are okay. So I do a small incision and then I use my pedal to inject. By the way, this knife is called flash knife by Fuji, bolt type. This is the water pump, right? Okay. All right. I hook the tissue, I use endocut. Okay. Now, we have cut the mucosa. The next step is to do the trimming. So now we will cut the muscularis mucosa. I will switch to blue current because we may encounter vessels. Like here, there is one. And I have a very special cap. This is called ST Hood by Fuji. It's a tapered cap. So the advantage of this cap is that it allows us to enter into the pocket more easily. Now, the next challenge is to identify the structures here, the anatomy. I will inject blue, and we're using the ACI mode by Fuji in order to better identify the muscle layer and the submucosal tissue. Now, a major skill in these procedures is to choose the axis of dissection by moving the endoscope in the way you want and then use up-down for cutting. So I usually don't use the small wheel. So now at this point I will go up. Maybe I'm too deep. Okay. So here, the muscle layer is at 6 o'clock. The mucosa is at 6 o'clock, but when I rotate, I can change the axis. So I will try now to create a tunnel. I will work with the classic image. So the problem with these procedures is that you can easily get lost and go at the right side of the lesion, or now we have from time to time to confirm that we have.
Settings of your electrocautery.
My electrocautery is endocut I2, effect 2, and the rest is 3-3 in duration and interval, but at this point I use forced coagulation for dissection, effect 4. If I encounter big vessels, I will switch to spray. we try to identify the whitish tissue of the tumor. Maybe something appears right here. Let me see if it's here. Okay, a whitish tissue appears at the middle of our screen. I suppose that this could be the tumor. Do you see it? I will touch it right now, this one. Okay? So now we start the part of the enucleation. I will go around the lesion. It's important to protect the capsule. Okay, yes, this seems to be the lesion. Okay, so we have identified the lesion. This was the first challenge during STER. And now we will try to enucleate it. All right. So you see, this is the tumor. I will try to go now above the tumor. Now, my knife at this point targets the mucosa. So we have to protect the mucosa against perforation. I have to be very careful right now not to provoke mucosal injury. I will switch to endocut because endocut is more precise. The cutting is less efficient, but we have more precision. I inject again and again. I push my scope. I switch back to forced coagulation. Try to enucleate the tumor. So many people ask, here I damaged the capsule. Many people ask, why do we remove these lesions? Do you know the answer? The short answer, and I don't want to be arrogant, is because we can. We can remove it safely. These lesions provoke stress to the patient, so that if we don't remove it, we tell them come to 1 year to 2 years for follow-up. It's a benign lesion, but we have to follow up, do follow-up, and one day maybe we have to resect it, maybe by surgery. So once the tumor is small, it's safe and relatively easy to remove it by means of ESD or STER. So my point of view is that nowadays, in 2026, it's time to remove these tumors. Only if we have the appropriate training, of course, and that means be experienced in both ESD and POEM. In addition, in 2026, we have many devices for closure. So we are much safer. So the difficult part will be to go beyond at the posterior part of the tumor. If I fail, I can still convert the procedure to standard, let's say, ESD, and open the mucosal cap. Also, I have noticed that when we do EUS with puncture, sometimes there is fibrosis, and we cannot detach the component of the tumor that touches the mucosa. Okay. Now it's time to go back. From time to time, we have to go back and empty the stomach because we have the tendency to put CO2. There is a lot of gas provoked by the procedure, and this deforms the stomach and makes the access difficult. So I aspirate. This is very important. In my hospital, the nurse has always her hand over the abdomen, and from time to time she says, please, doctor, aspirate the stomach. I go back, aspirate the liquids. We do have to administer antibiotics during this procedure. Have we given anything? All right, so we have to give prophylaxis with, for example, augmentin or ciprofloxacin, metronidazole, because we may induce perforation. All right, so this is how it looks at this point. All right, let's continue. Another point I would like to discuss. Once we remove the tumor, we will give it to the pathologist. So often the pathologist comments that the resection is R1. Do you know why he does that? He does that because the pathologist is used to receive wedge resections. And in wedge resections, the tumor has mucosa, submucosa, and normal wall around it. In this case, we do not do wedge resection, we do enucleation. So the answer is that the pathologist cannot comment on the R0 resection. He can only tell us if there is damage of the capsule. Okay, now I will switch to spray coag. I have multiple settings ready. So we have a major vessel here, and I use a more aggressive current. I have just to identify the vessel. Madalena asked me to show you blood and fat. If I don't succeed, I will use the coag grasper. It's slowed down. I will inject again to identify the vessel. Okay, the oozing comes from here. Yes, so I will use spray coag. It doesn't work. If it still doesn't work, I will not insist. I will ask for a coag grasper. Please give me a coag grasper. The setting for the coag grasper is soft coagulation 4 or 5.
Explain to us, please, where is the direction of mucosa in this moment?
At this moment, the mucosa is
It's up.
So we have to be very careful not to provoke mucosal injury. It's very easy to damage the mucosa from thermal injury. Yes? Everything? Yes. Please, hemostasia. Yes. Press the. So press this. Okay. So open, grasp. Now I have to pull back. I pull back, and I'm very careful. I press the pedal for 1 or 2 seconds. Okay, stop. Open. Now I check whether we have a good hemostasis. It's not perfect. One more time, and then I will stop. Close. I pull back. I touch the tumor, but open. Okay. I will stop, and if it continues to bleed, I will dissect the area around later. So I aspirate again. Now we have done the easy part. Now the difficult part is to go below. All right. Give me the knife, please. I have to dissect as much as I can before I induce the perforation. And we have also the option of traction in this case. Okay. It's not. All right, let's work here. Let's work here. I will work under saline. Okay, let's work under water, under saline for better visualization. Now, when we work under saline, we switch to endocut. Now we have to be very precise. We may do some intermuscular dissection right now. Okay, so we have started the intermuscular dissection. We see the muscle. I will try to inject and dissect as much as I can before I induce perforation.
Georgios, how long do you think it will last starting from this moment,
Approximately.
approximately?
It depends whether we will have any bleedings. Between 30 minutes and 1 hour, I think. Okay, now have a better submucosal plane.
Yes. Good.
The bleeding here.
Foarte bună injectare.
All right. So the advantage of having a very slim endoscope is that you can move around the lesion much easier, and here you can appreciate also the advantage of a tapered cap.
Thank you, Georgios, for the great demonstration.
So we have enucleated the lesion at both sides, behind the lesion, and now we have the strong attachment at the muscle layer. At this step, we have applied clip and line counter traction. So this is a dental floss, and the clip is placed over the tumor. And now I will pull back, and the attachment of the muscle layer is nicely exposed. At this point, I have changed device. I will use the hook knife, and we will probably induce a perforation or intermuscular dissection. Let's see. So needle out. Okay. You can rotate the knife. Please rotate the knife at, yes, there. All right. Okay, we induce a perforation, but that's the plan.
Georgios, I understood that there are some questions from the room. Can you ask them?
At this moment, it's a critical point. Give me
Okay.
a few seconds. Because here we have some big vessels. We have to be very fast and precise. Okay.
Stai pe peritoneu, uite. Ce gras. E o gaură până intenție.
The abdomen is still soft.
Yes.
I try to identify where I have to cut. All right. All right.
So you are like a surgeon, Georgios, now.
Okay. Wait, I have to identify the remaining. Yes, here it is. Oops. Oops. Ah.
A little bit more traction.
I have to yes, we need traction. I have to identify the remaining bundle that has to be cut. Okay, so here we are okay. So the disadvantage of STER is that you don't have good visualization. If we spend a lot of time and we're not able to complete it, we'll have to open it. But now I have here a good image.
Yes.
Open, please.
Yeah. Yes.
It's done. Let me see. Oh, it's still.
Good.
Wait.
You want to maintain the traction?
Ah,
Sure.
yes, it's outside now. You remove it.
I don't see it. I hope we didn't lose it in the peritoneal cavity. Please remove this.
Oh, I see.
Ah,
It's inside the stomach. A ieșit.
it's lost. It's detached. Ah, here it is.
Yes.
Okay. So, you just saw an intentional perforation. Let's close it. Then let's check the abdomen. It's good. We will puncture at the end of the procedure. Now, please give me the mantis clip. Mantis.
We don't have monkeys.
We have two. So now we have the discussion how to close it. The most okay, never use them, but they are very good. We can use them too. Let me find the area. Have to empty the stomach. Okay. So now we have the following problem. We have a perforation, and when I insufflate, I don't have good visualization. So that's the issue when you perforate. We have to identify the area of dissection. I don't find it. Where is it? It's somewhere here, right? Here. Okay. All right, here we are. Okay, now we have to check for blood vessels. All right, let's see whether we have to coagulate. It's good. Yes, that was a good movement. All right. Yes, with a big vessel. Okay, please give me the mantis clip. Now, I will place the mantis clip, which has anchor pronged design, and I will try to place it at the middle of the defect, and then use multiple clips around it. So I am able to rotate the clip by myself. Open it, please. So we have to use it very carefully. You will use it like a biopsy forceps. You will place it when I will say deploy. When I say close it, you will close it in the same way you close a biopsy forceps, all right? So don't deploy it, because we have to do the following technique. You will grasp here, close, don't deploy. No, I will do it differently. Open, sorry, open. I will go to the other edge here, the proximal edge here, okay. Close, all right, close. Now, I will push, open again, nice. Now, close, deploy, fire. Now, you have to open again, all right. So, what we have done now, with only one clip, we have almost closed the defect. We have achieved we have approximated the two edges. Normally, we have to use 4 additional mantis clips just to be safe. But I can use large standard clips. So give me the 17 clips. I will place them around this mantis clip to secure the closure. The mucosa is thick, so it's better to use mantis clip for this step. Open. I can still rotate it. Okay, let's try here. All right, here, it's good. I will rotate. You have opened completely?
It's open.
Close. It's good or not?
No. The other.
I'm not sure. Open. The other. Here it's better. All right. Close. It slips. That's why we have to use. Okay, open. Give me one more mantis clip.
Okay.
The other way we can do it is to use the endoloop technique, which the dot.
If you want to try.
Okay, we can try it again. I will use one more mantis clip. How much time do we have? We have 20 minutes? Because I can demonstrate the technique with endoloop, which is very interesting for everyone, I think. Open.
As much time as you want, Georgios.
Okay. Close. No. Okay. Open. It's not good. I will do the same as before. So, I will try to grasp the edge. Close. Yes. Open. Close. Okay, it looks nice. Place, please. Fire. Okay. Give me, let's try again a conventional clip to see if we can, or shall we use the endoloop? Endoloop will be more secure, we have a perforation. Okay, guys, let's do the endoloop technique. Give me an endoloop. So we will do a Chinese technique. We will place an endoloop over the scope, and we will attach it around our defect and then close the endoloop. This is the best way to close this type of perforations, the more secure. Now, what are the next steps? The next step is to puncture the abdomen in order to relieve the pain that the patient will have after the procedure. The patient will not eat anything, and tomorrow morning we will do a CT scan without anything, no contrast, no nothing. The role of the CT scan is to identify where the artifacts of the clips are located in the abdomen. Then we will give 4 glasses of water with contrast to the patient, no intravenous contrast, and he will drink them, and after 30 minutes we will do a new CT scan. This is the leakage test. This is the best way to identify whether there is an ongoing leak. So here is the endoloop. It is very important that you know how to use it. We will close it partially like this, and please give me a clip. So I will advance I will advance the endoloop over the scope. Please the camera focus on my endoloop. Professor,
Yes.
don't miss the specimen.
Yes, yes.
We did a lot of effort.
Yes,
Okay.
yes.
So,
May I take it?
okay, yes. Okay, so open the clip. We grasp the edge of the loop. Close it. All right, perfect. Now we introduce, we pull back here. Now I advance over the scope the endoloop, and I'm very careful not to injure the oral cavity. You may induce perforation like this. I pull back my clip, protect the mouth. Okay. So my concept is that we are good endoscopists not when we do impressive procedures, but when we can deal with the complications and be able to manage all scenarios. Then we become more confident, but never arrogant. So we will approach the area of the defect. Here it's almost closed. I will place the first clip behind the lesion over here. Please open the clip. Here. All right. Fire. Go. Perfect. Now, you will open the loop and you will give me more clips. Now we will need 6, 7 clips. The concept is to attach the loop around our defect, and then we will close the loop, and we will seal the defect in a very safe way. So I advance a little bit my loop. Open. All right, great. Close a little bit. All right, nice. Now we need to understand the anatomy here. All right. Nice. I don't see very well. Let's move here. I don't see. Open. I will have to go behind the lesion. Ah, yes. Here. Better view. All right. But this is, wait. This is the right part of the endoloop. We need the left. Or we can fix first the right. Yes, I'll do that. Please, grasp the endoloop. Grasp the endoloop. Not the clip, open. Yes, close, all right. I will place it here. Open. Close. Place, fire. Okay. Next. Yes, all right, that's good. Next clip. Prepare many clips, please.
Să mai desfaci vreo 2-3.
2, 3, 7.
7, 8.
Okay. Use the clip for traction. Yes, close. All right. We'll place this.
Îți rocolește, că altfel nu faci nimic.
All right.
Altfel
Open.
se nu-l închizi.
Open. Close. Fire. All right. Next. This is the way I close the defects after G-poem. This is what I usually do in case of mucosal injury of the cardia, because in poem, if you do injury of the cardia, it's not always easy to place clips. Open. Okay, so we have to be very careful. All right, here. All right, place it. Open. Open.
Okay.
Close. Place. Fire. Yes. One more. Next clip, please.
One in the
So-
left, one in the right.
Yes. So, and we attach multiple clips around our defect. I understand that this is an expensive closure, but this is the best way. Open. All right. Let's. All right. So, yes. It's good there? What do you think? I don't see very well. Okay, step back. We have to understand what's going on. Open. We don't see well. Let's understand. All right. Yes, so I have to pull back my endoloop. I will yes. I will pull back my endoloop to straighten it. This endoloop has to be fixed here. Open. All right, here. Here is good. Open. All right, close. Fire. All right. So the right part is done. We have to complete the left side.
Da. Unul cel puțin. Another 2, 3.
More. Open. All right. Okay. Close. All right. Open. Close. Fire. Next.
Încă.
Open. Close. All right.
Nu știi să-l pui, că nu pui oriunde. Nu se închide după aia.
Open. Close. Fire. Okay. Now we have. Oops. Have to close a little bit the loop, but yes, pull back. Okay. So close. Yes, like this, a little bit. Opa, let me see. Wait. Where is the loop? You closed the lot. Okay, open it. Yes, yes, now it's good. All right. Now we have to grasp. Yes, I understand now. Give me the next clip, please. The left side needs to be there, yes. You have to attach the left side. Open a little bit, just to grasp the... All right, close, all right, good. Now we have to go here, in front of the lesion. Here, open, close. It's done, okay, fire. Yes, 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 very good. Probably two more. And now I can grasp, yes, these two sides and we're done. Yes. Okay, open. You have enough clips for the other procedures?
Yes.
Close. Okay, now it's good. Yes, good. Fire.
Fire?
Yes. Okay, one last. I will grasp with the last one both sides of the loop, and then we will close the loop. Okay. Nice. All right. Great. Here. Perfect. Oh, no, open. I have to grasp more mucosa. All right. Close. Fire.
Fire?
Yes. All right. And then, now I need the last one. With the last one, I will attach both sides of the loop. Yes. One more clip and we're done. And then you first you close, and then you tighten it. And then we have to, the abdomen
It's very soft.
is soft, but yes.
Probably we don't need puncture.
Okay, open. Okay. I rotate by myself. Okay, open well. Open. Yes, nice. I want to grasp everything together. Close. Do we have mucosa? Yes. Yes, we have.
A little bit.
We have.
Okay.
Okay. Fire. Yes. Okay, now you close the loop. Wait, I will step back to watch what you're doing. Okay, close it. I will push. Close. Okay. Now, be careful, huh? You closed it? Okay, try to tighten it slowly. Try to tighten it slowly. Yes. Tighten slowly. We need a lot of resistance in order to have a secure sealing. Close, yes, close. I don't see the stopper yet. Close, yes, go. Okay, tighten it. Don't be in a hurry to, okay. It's good?
Yes.
All right. Deploy, release.
It's released.
Oh, yeah, it is released.
But it's under the scope. You don't see it.
Okay, release it. I will pull back. It's stuck. Oh. Don't worry, I also have the endoloop cutter in case it doesn't. Okay, done. All right. Let's check. Let's check.
Le-ați strâns pe toate.
All right, now we're done. Huh?
Do we need tomorrow CT scan?
Tomorrow CT scan without contrast, and then with oral contrast.
In case the patient is okay.
It's been only for blood come to